My pleasure to be here and give you this short overview on PSMA theranostic. Next. These are my disclosure. As I used to say, my main disclosure is that I'm proudly a nuclear medicine physician. So what you will hear is a talk by a nuclear medicine perspective. So let's start with a bit of history of theranostic. I'm sure that you all know that, but it's good to have in mind our history and root when we start considering the present and the future of theranostic. So let's start with the definition. Again, everybody knows what is theranostic, but it's good to have in mind that it's a process will keep together diagnosis and therapy. And the goal is that individual patient should be tested in order to demonstrate that there is a target that could be used for driving either imaging and treatment. So it's purely personalized medicine. Again, everybody knows that, but it's a very simple cartoon that I like to propose to, for example, our friend oncologist or the student of other specialty. The cancer cell has, of course, overexpression of some target, and that's what we want to really address. That's to say, we have a ligand, which is a radiopharmaceutical, and it's going to be binded to the target very specifically. And if we have an isotope, which is, for example, a positron emitter like gallium or fluoride, we can see the cancer. But we replace the isotope with a killing agent like lutetium, yttrium, or actinium, and we have the theranostic effect. So we can cure. This is very simple, but it's good when you want to show to your colleagues how essentially it works. Next. So the history comes very far, and you will have the privilege to hear that later on today in your program. It comes from the 40s, so meaning that it's really 80 years old, and Sol Earth made it fantastic by creating the iodine therapy. So after the successful introduction of iodine therapy by Sol Earth, that was of course used to cure thyroid cancer, the next big success of theranostic was in the field of neuroendocrine neoplasia, so they also called neuroendocrine tumor, by the use as a target of somatostatin receptor that was successfully introduced in the 90s and then moved on rapidly. In about 10 years, it's been established with yttrium first and then lutetium dotatate. And the concept is absolutely the same. You have overexpression of somatostatin receptor on the surface of a neuroendocrine tumor, and you can use for imaging and for therapy. And these are the impressive data of the NETTER trial, because you know the principles are fantastic, but if you want to convince the oncologist, you have to run good trials like this trial that was multicentric, prospective, randomized, and it demonstrates a clear advantage when you're using lutetium dotatate over standard therapy in neuroendocrine tumor. And this is really impressive. If you see the difference between the lutetium dotatate and the standard treatment, it's clearly in favor. And this has led to the incorporation of lutetium dotatate into the guideline, which is also very important because we need recognition from the oncological colleagues. And then it comes with our target, which is PSMA, which is overexpressed in prostate cancer. That's very important to have a very specific target which is clearly overexpressed in the majority of prostate cancer. So what we want to do is to treat patients like the gentleman on the left that have an increased expression of the target. And what you don't do is treating patients with, like the gentleman on the right, a very low expression of PSMA. So essentially, you treat what you see. And don't forget that not every single cancer cell express PSMA. There is always a small percentage of patients which has no overexpression of PSMA, like 5% of gentlemen cannot be treated simply because they don't overexpress the target. So let's now go into prostate cancer theranostic. Yeah, this is an example from Heidelberg. We are all very thankful to Uwe Haberkorn, Professor Haberkorn in Heidelberg, essentially introduced the therapy. This gentleman has already been treated with almost every possible therapy. You know, there is impressive spread of the disease everywhere, especially in the skeleton. This is the very first patient, again, treated in Germany, in Heidelberg, and you see, first was imaged with gallium PSMA, and then treated with more than one course of, in this case it was lutetium PSMA. And you can see that you can follow up the patient either with imaging and with the classic PSA values. This is the first multicentric trial that was run in Germany. You see in the waterfall plot that about half of the patient has more than 50% decrease of the PSA, which is a good result, but that was a retrospective trial, so it's not high quality trial. Okay, and this was the first good trial, scientific high-quality trial published on the Lancet and run by the Australians that was demonstrating that finally treating with an established regimen of lutetium PSMA, you have good PSA response in more than 50% of the patients. And this led to the conclusion that a multicentric trial should be done. The previous study was a phase 2 study, so the Australians designed a phase 3 trials, the very famous therapy trial, which is published in the Lancet. It was 2 years ago. In this case, the patients were randomized to receive PSMA lutetium versus the standard of care, that is cabazitaxel. And patients were randomized and the results were compared. The endpoint was the PSA response. And you see that on the right, the PSA response was much better as compared to cabazitaxel. So clearly superior to the standard chemotherapy, which is done in patients. Of course, we are talking about patients with advanced cancer. These are the curves, again, an advantage of lutetium PSMA over cabazitaxel in metastatic castration-resistant prostate cancer already treated with ARSI and with taxane. The side effects were much in favor, again, to lutetium PSMA, so fewer grade 3 and grade 4 adverse effects. And this is the cartoon, nicely summarizing the result of therapy trial. That is really a milestone. And after that, the VISION trial came. It was run in North America, it was sponsored by Novartis, and in this case, the randomization is 2-to-1, and it was lutetium versus standard of care. Again, gentlemen who already have exhausted the majority of therapeutical option in metastatic CRPC cancer. A large number of patients were enrolled, and in this case, the primary objective, the primary endpoint was survival, and this is probably the best endpoint you can get, and there is a clear advantage, again, of lutetium over standard of care. And this has led to the registration of lutetium PSMA in North America and in many other countries, including Europe. So the treatment was associated with some toxic effect, but not so relevant. Everybody knows the main toxic effect is about the blood and the salivary glands. And again, the cartoon summarizing the VISION trial that was successful and, as said, led to the registration and the clinical use of lutetium PSMA. This has led to the incorporation into the guideline. That's to say that right now for patients with metastatic CRPC, lutetium PSMA is recommended by all international societies. And also, of course, this is the first one was a European, this is the American guidelines that have been updated last year to incorporate lutetium PSMA, which is now commercially available and widely used in North America and many countries in Europe. So which is the current practice and some current problem with the adoption of PSMA? Well, everybody knows not all the patients respond to PSMA therapy. That's to say, we always have something like 20%, 10 to 30%, but an average of about 20% of patients which are not responding. And what we have to do is to identify those patients, because we don't want to treat patients that will not benefit from an expensive therapy. So we need some strategies in order to identify the small part. You see, these are in the blue, the right part that goes up. That's to say their PSA is not lowering, so they will not benefit from PSMA lutetium. And which are the solutions? Well, there are different solutions, and this is probably one of the main current problems. We may add scan or we may use nomograms. This is the Australian response. In the therapy trial, they added FDG scan. It's suggested by them. The concept is simple, just like for neuroendocrine tumor. If the cancer is FDG avid, then it's likely to be very malignant, very aggressive, and non-responding to lutetium. Previous speaker has already showed an images. What is here is the concept that if you are PSMA positive, then you can be treated. If you are PSMA negative, or if you are PSMA positive, but there are lesions which are FDG positive and PSMA negative, then the patient is not to be treated. This is the Australian approach for increasing the likelihood of response. The Americans, I mean North Americans, made it different. They also used the scan, but it was a conventional CT or MRI. That's to say, they got the information from the CT part, and in case they see a lesion at CT, which is cold, so not avid of PSMA, they decide to not treat it. The lesion should be of some relevant size, that's to say, it's measurable, some centimeter, different the size if located in the lymph node or if located in a parenchyma, but the concept is to exclude on the basis of CT or MRI scan. The exclusion rate with the Australian FDG approach was 28%, and with the North America, which is more conservative, was about 13%. So other factors could be derived from the PSMA scan. We have the scan that demonstrates the overexpression of the target, but we can also use some other information, as everybody knows, like the SUV, the homogeneity of the target expression, and the low or high whole body volume expression of the target. So, for example, if you have a very advanced disease, the very heavy and high volume is worse. That's to say, the earlier you treat the patient, the better it is and the more likely that the patient has a response. And you have several strategies to calculate this, to calculate the volume, to measure the SUV, and they can also be incorporated. And the concept is you can have some clinical data and some lab data, you put them together with the SUV, with the tumor volume, and you have a sort of a predictor, or if you prefer, a nomogram. And that's been done by the colleagues in California. You can also access that online, and you put all the information of the patient, and you have a calculator. The calculator is giving you a prediction, a percentage of success. It's not stratifying patient in responder and non-responder, and that's the limit. That's to say, you can predict if the patient has a high probability or a low probability, but you cannot really exclude patients from treatment just because the likelihood of response is, let's say, 50%, because in most cases those patients will not have an alternative. So let's see now the future. What can we expect? And I'm happy to tell you that the future is really now, because literally few hours ago, one of the most expected trial has been reported at ESMO. It was the PSMA-4, and well, here are two other trials, which are the lutectomy, which is to say using PSMA much before CRPC, so in patients which are still in an earlier phase of the disease, because essentially the trend is to that, not waiting for the patient to be castration resistant, but adopted before. I was mentioned the PSMA-4. I'm sorry, I cannot include a slide because it has literally been presented yesterday, but it's in patient which has not received taxane yet, and the results are impressive. An alternative is to change the isotope. We already heard about actinium. This is one of the first trials with actinium. You know, few patients. The phase 3 is still ongoing, so we don't have good evidence so far, but of course it's interesting to use them. As said, what we want is to use it as soon as possible. So right now we are treating metastatic castration-resistant prostate cancer. We want to move before taxane, and as said, PSMA-4 have been reported, and the advantage in terms of survival is impressive. But we want to move even further, so in hormone-sensitive patients, and probably even before. Well, in conclusion, and again, many thanks for inviting me, for not being able, so sorry to be there and some technical problem. Theranostic is a fantastic approach. It really helps the future of our specialty because it's growing in an incredible, fast and successful way. It's a clear example what we can achieve. It was really one of our first patients, and it was also a colleague, by the way. You see, in 2017, he has a spread of the disease. He went to Heidelberg and was treated with lutetium PSMA with a fantastic response. And what it's important to me is to emphasize the great quality of life that my friend got it because he was really working with us before, and the duration because this patient unfortunately passed by, but after almost 4 years of great quality of life. He was treated 2 times, first at Heidelberg and then with a cocktail of actinium and lutetium PSMA, and that's exactly what we can achieve in our patients. So theranostic, in conclusion, is an approach integrating diagnosis and therapy. It's used since many years. The terms is relatively new, but the use is very long-lasting, and it's based on in vivo demonstration of the target. It's the most rapidly growing area of therapy in nuclear medicine, and it's used in right now metastatic castration-resistant prostate cancer, but more indications are coming. As said, it's clear that after PSMA4 presentation, there will be more indication for the patient. And my last slide is just to thank you. Thank Sadia for the fantastic job she's doing, for the invitation, and a pleasure to collaborate with you. We're planning to have one colleague of mine coming and run a course in Pakistan, and compliments for all your achievement. And again, thank you so much.
Any questions with Dr. Fanti from the audience, please? So if you have none, I have a question, Dr. Fanti, that what do you think the problem of treating with lutetium PSMA if the dose fractionation is reduced with the higher activity to be given rather than just giving 7.4 gigabecquerels per fraction? Do you see the problem of non-responders is going to change with that or not?
Wow, that's a fantastic question. I wish I could really address this question. I would be really a great scientist. I mean, the problem is much complicated. We really don't know which is the problem. We don't know if we should increase the dose, if we should. Some people is trying to administer like enzalutamide or other drugs in order to promote the increase of receptor, because of course if you have more receptor you can more effectively treat. So your question is fantastic, but I'm not able to address it. I don't think, I mean there are of course many studies ongoing on that. I don't think that it's really an issue of dosimetry, but rather a matter of accepting that some patients have too low receptors, and at the same time their cancer it's probably too aggressive to be effectively treated. We should try to identify them before administering lutetium.
Okay, thank you. Lastly, I would like to apologize on behalf of PSNM that there had been some internet issues on our side. Although we had your recorded talk with us, but we could not run that and you had to do it again. Thank you so much. And there is another question from the audience as well. Please.
Thank you, Dr. Fanti, for an excellent talk. This is Dr. Amna Hassan from Shaukat Khanam. My question for you is, what do you do when, as right now, most patients are pre-treated with all sorts of therapies and they come to us with pretty low platelet counts. So again and again, we're facing this. We keep the threshold around 75,000, and into the therapy, second, third dose, patient sometimes even bottoms out. We've seen 28, 20. We've seen symptoms, and clearly the patient is responding to lutetium therapy. So what do you do with low platelets? That's one question. And the other one is, have you gone beyond 6 cycles? You have an excellent responder who's doing really well, but since 6 therapies are what is approved, have you ever used beyond 6?
Again, I'm sorry, I only got the first part of the question because then my internet was frozen for a while, but it was an interesting question regarding the bone marrow activity, the platelet count. I'm fully with you. Sometimes the patient comes to a very late stage of disease with the very exhausted, I would say, bone marrow. And we know that there is a toxicity on the bone marrow. So we want to avoid to bring any, severe effect in these patients. I have to say, usually interference of taxane and also of radium is not so relevant. Sometimes we wait a little bit, sometimes we administer a lower dose in case the platelet count is like 50,000 or something like that. You are trying to adopt your strategy to the individual patient. So you can either try to promote or wait a little bit, but we all know it's patients that sometimes they cannot really wait a couple of months because their expectancy of life is sometimes very short. That's why I emphasize the need to treat the patients before they come to a very advanced stage of the disease. Probably this is the only solution. Now we are just facing the very late application of the therapy, but we are moving much before right now. So I'm fully with you. Different strategies, but not one only solution that may really fit. Probably reducing the dose is the solution, but at the same time, if you reduce the dose, you reduce the likelihood to get a response. So it's a different balance that you have to keep in mind. And I'm sorry, but I didn't hear your second question.
So my second question was, have you gone beyond 6 cycles ever? If a patient is responding well, do you go beyond, or do you wait a bit and then give them another few doses? Your experience in that?
Yeah, I have to tell you, in Italy it's not possible with the present regulation to go more than 6, but as the patient that I showed you, in Germany this is done, and usually if it's a good response or a strategy could be to administer 4 cycles and then decide if moving further, or just like in the gentleman that I showed to you, wait. And, if the PSA goes fine, that's to say is not rapid and clears, you can consider to retreat the patients when the PSA starts raising. Again, you have to adapt to the individual patient. So there's not one strategy that could fit for every patient, but yes, it's clear that you can treat the patient with more than 6 cycles. You just have to, if you already achieve a PSA like a very, very low value, probably you can keep this for a later moment.
Thank you.
Okay, with this, we come to the end of the session with Dr. Stefano Fanti. Thank you, Dr. Stefano, for such a nice presentation and answering our questions.
Thank you so much. Thank you so much.
Thank you.